Bismillahirrahmanirrahim. So today's session is on the management of pulmonary infections and cystic fibrosis. And we have Dr. Ali Akbar with a short introduction. Dr. Ali Akbar is a consultant respiratory pediatrician from Birmingham Children's Hospital, and he's a lead physician in managing the cystic fibrosis network group, which is operated through a different sessions on YouTube, and we have a WhatsApp group and different forums of teaching and learning at different hospitals in Pakistan, throughout the Pakistan. So I would like Dr. At the end of the session, we take some questions, and if you have any questions, kindly write in the chat box, and we will take up those questions at the end of the session. Thank you very much. Over to Dr. Ali Akbar.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Danish, for inviting me and also for your kind introduction. As you know, cystic fibrosis is very close to my heart, and I would love to talk about these topics on cystic fibrosis anytime. And I'm so grateful for your kind invitation to give me this opportunity to talk about this very important condition, which is quite under-recognized in Pakistan at present. But with the passage of time, I think there is a raised awareness, and people are now making the diagnosis more readily and easily, although there are issues which I will touch on during this discussion as well. And I call this the management of pulmonary infections rather than the treatment, because I think treatment is very simple. Once you know what bug it is, what sensitivities are, you can give the antibiotics and that's it. I think management is very crucial because we need to think about other aspects of care of the disease, the illness as well. So I will be spending quite a lot of time around the other aspects in prevention of the infections as well, and then mention the treatment aspects as well. So just before I start, I just want to declare that there are no conflicts of interest, and this is not a sponsored meeting. This is purely educational, and any antibiotics or any medicines that I may mention are not through any personal interest or so. It's just purely the ones that we tend to use commonly in our setting. And the objectives of the talks are to give you some background, which is, I think, very important, and it would be raising the awareness and also acknowledge that there are issues with diagnosis or other problems in managing cystic fibrosis in Pakistan, and then also identify the contributory factors to the chest infections in cystic fibrosis, because I very strongly believe in prevention is better than cure. And then we'll discuss about these preventative strategies as well, and then discuss some of the common respiratory infections. Obviously, it's going to be difficult to cover everything, all the infections, but we'll cover the common ones. Now, with regard to the background to cystic fibrosis, this was identified as entity in 1938. So it's been about 80 few years that it's been around, and the family studies had recognized back in early 40s that this is an autosomal recessive condition, and subsequently was proven to be the case. And it is a lifelong, it is a genetic disease, it's a lifelong, because I see very often parents asking me, how long we need to give the treatment? Do we need to give the pancreatic supplements for a month, a day? What's the course? And they don't realize that it's a lifelong illness, and so long as the person is there, they need to carry on with the treatments. And not only lifelong, unfortunately, it is life limiting as well, to the extent that when the disease was actually described, people were dying in their pre-teen years or preschool age, which is now the case, but it is about 40, 50 years median age in the West, and we'll discuss that later on as well. With regard to Pakistan and background, there is a lack of data, awareness, and also diagnostic services. And when it is diagnosed, there are difficulties in accessing the medical services and also the affordability element. And I know this sounds all very negative, but I want to capitalize on this one. And I want to just highlight to the residents and all the junior doctors around in Aga Khan and elsewhere in Pakistan, that there are opportunities, although this is lacking the data or awareness of the disease or diagnostic opportunity. But these are the sort of things that you could actually capitalize upon and dwell on these things and improve these things and work on these. And hopefully you'll become experts in these things as well. So these negative things you can turn into positive and potential opportunities for the future. And just to mention that in the UK, we normally have about 700 births in a year. And the incidence of the CF is 1 in 2,500 patients. So roughly we get about 250 to 280 babies born in the UK each year. On average, about 5 or 6 a week. As opposed to Pakistan, who's got 10 times the number of births than the UK. Nearly 6.8 million births, and that was the figure for last year. We do not know the incidence of this disease in Pakistan, and that's where I'm talking about the lack of data. But based on the numbers of the Asians within Europe and United States, it's estimated that 1 in 10,000 births from Asian countries may have cystic fibrosis. And the other lower is 1 in 30,000. So somewhere between 130 to 130,000 births in Pakistan would be with CF. And based on that one, the estimated new babies born in Pakistan with cystic fibrosis would be about 225 to 675. So this is the sort of range, but we really do not know. This is pure estimates as we have at the present time. And if it was 225, that is similar number to what we have in the UK, and the facilities and the resources that we have are a lot more compared to what is in Pakistan. So I think it just we need to get more data on it to establish the incidence and see what numbers we are dealing with. And these are numbers based from our UK CF registry, and I'll compare it with the CF Foundation in America as well. And these are the reports that we have published every year. And this is giving the numbers from 2016 to 2021. And the number of CF patients has gone up from nearly 9,500 to just over 10,000 or 10,500. So there's an increase. Like I'm saying, there's about 5 babies born each week in the UK with CF, and there's generally on average about 3 deaths each week. So there's a surplus of 2 newborn babies every year. So that adds on to about 100 patients every year to the number of CF population that we have. And also the number of adults is also on the increase. So we, out of the about 10,500 patients that we have, 62% at the moment are adults over the age of 16. If you go back 15 years, 20 years, the pediatric population was more than the adult, but because the survival is now better, the children are surviving into adult life, the adult numbers have taken over. So we have more adults, and the median age of these babies or these patients being diagnosed is 2 months. So by the age of 2 months, most of these are actually diagnosed. And that is because we have newborn screening in place in the UK. So every newborn baby is screened for cystic fibrosis, and therefore the pickup rate is much better. Before the newborn screening, it's still the median age of diagnosis was about 7 to 9 months. So it was quite a quick pickup because people were clinically looking at the symptoms, etc., and then doing the appropriate tests. And of note on that slide, you can see that 99.1% of all our CF patients have been genotyped. So we know there are mutations in the majority of the cases, and where we don't know, either they're not been done or there may be rare mutations that we've not been able to pick up at the moment, as opposed to Pakistan, where thanks to Dr. Danish for his efforts at Aga Khan, there is now some CF monitoring going on, CF testing going on, and we also got a similar process in Lahore as an area as well. So there are more patients being genotyped in Pakistan as well. And looking at the Pakistani figures from UK, for example, over the last 10 years, the number has increased from 139 patients from, say, Pakistan origin to 183. So, and they account for 1.6% back in 2021 to 1.8% of the CF population in 2021. So the numbers are there. Obviously, it happens in the UK, it happens in Pakistan as well. And we have been seeing more patients diagnosed with cystic fibrosis in Pakistan. And as you would also know, cystic fibrosis is a multi-organ disease, and it affects anything from the head down to the toes, basically. And I have highlighted these areas which belong to the lungs, starting from the nose with the nasal polyps, etc., or sinuses, down to the lungs and all different conditions that it can involve in the lungs as well. So it is the lungs are one of the commonest organs that are affected. But there are other presentations that happen with meconium as to 10 to 15% of the babies will present with meconium at the time of birth. And the others may present with the lung infections, malabsorption, failure to thrive, conjugated hyperbilirubinemia, rectal prolapse, babies being kissed and tasting salty, or electrolyte disturbances with pseudobarter-like picture as well. And there are some adults, and we have a few in Pakistan as well, who actually presented at adult life with infertility after being married. They weren't able to get the children, and subsequent testing has shown that they actually have CF. In UK, for example, the newborn screening obviously has led all the diagnosis, and diagnosis now made a median age of about 2 months. This is what the picture used to be in 1940s when the CF was being discovered, described, and most children did die before the school age. And at that time, Staph aureus-like infections were the common reasons. And then, as you would remember, it was 1940s when the penicillins were discovered, and the infections were being treated very effectively at that stage as well. And then subsequently, once the Staph aureus was under control, Pseudomonas became a more prevalent organism back in late 1950s. And that is one of the commonest bug that we tend to see in the CF population. And it does affect the lungs in the chronic cases with the inflammation in the lungs, decreased lung function, and ultimately causing death in most of the CF patients due to chronic respiratory failure. Just to give you some figures from, this is the CF Foundation, American Foundation, and just to give you how things have improved over the years. So they've split the patient into 10 groups under 10 years of age. This is on the left of the slide. In the middle of the slide, the green lungs, that is for 18-year-olds, and then on the right side, the purple, and that is for 30-year-old. And you can see under 10 years of age, previously in 2002, the lung function, this is FEV1, that was about 89%, which is pretty good. But now that is 102%. So huge improvement over the last 20 years. And that improvement has been shown in the older age group as well, with the 18-year-old having lung function improved from 73% to 96%, and for even older patients from 56% to 79%. And that is immense achievement. And this is reflected in our UK data as well. And this is the data from 2021, which was published just about 9 months ago, back in September 2022. And you can see they split the data slightly differently here. They got it under 18s, where the FEV1 has increased from average of 88% in the past to 92%, and in older children, older adults rather, from 66% to 72%. So slightly smaller increase, but certainly an upward trend over and this is only over 2 years, into 2020 and 21, whereas the data you saw in the last slide, which was this one, that was over a 20-year period. So if UK data, that improvement is over a year. If you go back 20 years, it would be very similar to the US data as well. And this also shows with lung infections, people who are getting respiratory exacerbations and needing intravenous antibiotics. So back in 2018, in the CF Foundation data from America, 43% of the adults had at least one set of IVs in the year. And then that 20 years down, that 43% has come down to 15%. And in children, 23% had at least one course of intravenous antibiotics back in 2018, but that has dropped down to less than 50% of that number, down to 10% of children in 2022. And this is, I think some of that comes through the last 3 years of COVID pandemic, when people weren't even meeting each other. They were wearing face masks. There were a lot of preventative measures, there's hand washing, all sort of preventative measures going on as well. On top of the effects that we are seeing with the modulator treatments, which are the mutation-specific drug therapy for cystic fibrosis, both these things have brought this in need for intravenous antibiotics dramatically. And this is the UK numbers, similar numbers back in 2020. This is over a 1 year period from 2020 and compared to 2021. The 39% came down to 24%. And this is all intravenous antibiotics at that stage. So overall, both in the UK and United States, the lung functions has improved, and also the number of antibiotics and respiratory exacerbations has improved, although some of that is due to the therapeutic agents, the modulator treatments that have been on the market in the last decade or so, and also due to the COVID precautions that people been taking. And as a consequence, you can see the number of lung transplants required in the United States has come down from 259 in 2017 down to 53 in 2020. So again, this is because of the better lung function, better care overall, where adults and CF patients are not requiring lung function as much. And the survival has, as a consequence, gone up as well. And this is, again, the CF Foundation United States data from 2022. And the number has gone up from 56 for those children or those people born in 2018 to 2022. We anticipate them to now live up to 56 years of age. Just think about this when in 1940s, when children were dying before the school age as well. So compared to 5 years of age of death, now we're expecting them to live mid-50s, and that's a huge improvement in itself as well. And this is the UK data, which reflects very similar things. Back in 2020, the median survival rate was 50.6 years, and the currently reported data is 53 years. So not far behind America. UK tends to lag just a few years behind America because of all the advancement and other resources which are better off in America. They lead sometimes in the medical field, and then the others follow. So we are not far from there, and the Canadian and German, their data is very similar as well. So people are living into 50s nowadays, or we expected to live into 50s, those who are born nowadays. And this is overall the UK data of the survival of CF patients. So you can see from 2007 to 221, it's gone, anticipated survival is from 43 gone up to 53 or thereabouts. So we have about 10 years survival improvement over the last 20 years in the UK as well. And this is all due to all these things that have happened over the last 30, 40 years with centralized care, with all the nebulized antibiotics, the mucolytic agents, IV, and nebulized antibiotics, and very recently with all the modulator treatments, this Trikafta or MB and our Caftor. And what to come, we don't know yet, but it's all good news for the future as well, that things are likely to carry on improving as well. So we need to identify what are the contributory factors before we can impinge onto the treatments as well. So if we can identify the contributory factors, we may be able to stop these infections in the first place as well. And just to highlight that there are CF mutations, for example, and this is highlighted that there are lots of CF mutations that cause cystic fibrosis, which leads to chest infections. And there are other genes, what's called the gene modifiers. And these are the other genes within the nucleus which affect the CF mutations and affect their behavior. And this is why even if you have two identical twins, their CF disease may be quite different, because they may have the same CF mutations, but the other mutation, the other genes that they carry and the other DNA they carry may be different from each other, and there may be different gene modifiers, and therefore their presentation or their typical genotyping, etc., may be similar, but phenotype may be quite different as well. So gene modifiers are quite important in controlling some of the CF mutations and their action, and they may change how one gets the chest infection as well. And on top of that, there are then environmental factors. Obviously, for example, somebody's got respiratory infection and you go into the proximity of that person and they cough all over you, and one has CF, then they are quite likely to catch that infection. And this is what I was saying, that during the COVID period, when there was isolation and there was measures to control the spread of infection, the CF patients got fewer exacerbations, their lung function improved, and overall survival is better in those patients as well. So there's environmental factors that also affect, and we need to be able to identify these to actually stop these happening. And then if they do happen, then treat them appropriately, and the treatment options are also improving over the time as well. So what are these things that we can control? CF mutations causing the chest infections. Now, this is the dramatic presentation of how the CF mutations cause the chest infections. So we basically have the genes in our nucleus that code for the CFTR. And this leads to the defective ion transport at the epithelium level, where the chloride is channeled across the epithelium cells from inside the cells to the outside. And as the iron chloride moves across, the chloride takes sodium with it, and sodium chloride then brings water with it and hydrates the surface epithelium. But if there is no chloride, there won't be any transport of the sodium accumulation there, and there won't be any water there, and therefore the surface epithelial cells become quite thick. So there's a dehydrated surface area as well, and that dehydration leads to defective mucociliary clearance system. And this ASL is very important in cystic fibrosis, as this is made up of quite a few layers, and this is what keeps the cilia moving. And also it contains lots of other proteases, antiproteases, oxidants, and antibiotics called defensins, which actually do fight some of these bugs that we breathe into our respiratory system, and they clear them out. And I have this video and acknowledge Cystic Fibrosis Foundation for it. I'll play it for you and show you what I mean by this mucociliary clearance thing. So this is the basically epithelial surface. These are the cilia moving in a very good pattern, and these are the chloride channels allowing the chloride into the from inside the cells outside over the epithelium cells. When there is cystic fibrosis, you don't get that transfer, and these chloride channels remain within the cell, and there's no transport up there. So these cilia, these are moving normally. When there is no chloride channels and there's thick mucus, then cilia don't move, and therefore the gunge sits, all that bulgum and phlegm is sitting on top of the epithelial surfaces, and the airways then do not work properly because the mucociliary clearance has given up. And that's where the mucus then concentrate, the bugs sit in, and they cause the infection. So all these infections then cause to inflammation and mucus obstruction. So this triangle of infection, inflammation, and mucus obstruction becomes a vicious cycle, basically. So more mucus production there is, more infection there is, and more infection there is, there will be more mucus production and inflammation, and it goes round and around. And this is what ultimately causes lung damage, bronchiectasis, chronic respiratory failure, and death. And therefore, these three things, the mucus obstruction, infection, inflammation, needs to be tackled very carefully. So if we're talking about this triangle, and just saying that the 2,114 mutations as of yesterday, these are the different mutations that can cause cystic fibrosis. And if, for example, we were able to correct those mutations, and this is what I'm talking about, the modulator treatment that I highlighted earlier, then we may be able to correct that chloride channels, and therefore we could improve the mucociliary clearance, and therefore there won't be any phlegm sitting on the epithelial surface, there won't be any infection in there, and there won't be any chronic inflammation or deterioration of lung function. So one of these things is the correction of the underlying defect that we have. And just to go through, and there are different groups of these mutations nowadays. Previously, people just used to say CFTR gene, and that's the only thing. And this diagram just shows the normal DNAs that transcribes the CFTR RNA, that results in the making of the protein, which gets along the cell epithelium, and then you have normal chloride channels there. So this is all normal. This is in a healthy person. But when you have class 1 variants, this is where you have the CFTR DNA, but there is no RNA made at all. And if there is no messenger RNA made, there is no protein manufactured, and therefore there are no chloride channels at the epithelial surface at all. And these children will not be able to live. And this is the most difficult one. If there is no protein, you can't actually help it to get to the surface or do anything. So this class, basically, there isn't any specific treatment for this at all. But there is the group 2, and this is the one where the delta F508, which tends to be the most common mutation in cystic fibrosis. This belongs to this particular case. And this is where you have the protein made, which is a defective protein, which gets stuck onto Golgi apparatus. And there's a problem with its trafficking to the surface epithelium. And therefore, because it doesn't make it to there, you can't get the chloride channels made up. But there are no medications that can help the protein to get to the surface and do that. And these are called the corrector medications. And we'll discuss it in a few minutes as well. Then there's the group 3. So group 1 is where there was no protein at all. Group 2 is where there's a protein made, but is a defective protein. It can't make it to the surface epithelium. Group 3 is where the protein is able to get up to the surface epithelium, but the gates are not open. So the chloride channels are not open. The protein is there, but channel is not effective. And that's where the potentiators, etc., can help. They open up the gates, and we'll have a chat about that as well in a minute. So that is the mutation group 3. Mutation group 4 is where you have the RNA made, you have a protein made, and it gets into the surface epithelium, but the channels are not working 100%. There's a decreased channel conductance. So it's not 100% working. It may be 50%, it may be less. So it's a variable thing. So people don't have as many symptoms, or maybe a milder form of things, and more amenable to some of the medications as well. So that is group 4. Then there's a group 5 variants, where you have the messenger RNA made, but not all the messenger RNA is normal one. Some is defective, and as a consequence, you get a small amount of the normal protein made. So the protein is normal, but it's in reduced amounts, and that's very similar to the reduced function at the epithelial surface. So this is effectively very similar to type 4, but through a different mechanism. So that is type 4. This is type 5. And then there's type 6, where you get the normal protein, it goes on to there, but it tends to be broken up very easily. So it's broken down very quickly within the cells. So it doesn't last as long. So effectively, this again is just the group 3, 4, 5, 6 are very similar in that group, that you don't have enough of the protein function because of various processes. So these processes are very important because there are medications that are working at different stages of that protein being synthesized, carried to the epithelial surface, and the conductance of the chloride channels through their gates, etc. And this is what the work has been over the last 30 years since the discovery of the CFTR. And currently, I've omitted some of the medications that are not now commonly used, but the ivacaftor was the very first one which became known about a decade ago. But this was only able to be used for those where the protein was able to make it to the surface, but the gating wasn't working properly. It wasn't opening up the gates, or they weren't as effectively opened. And initially, it was for children over 6 months of age. But now the license has come down to over 1 month of age. And as I said, quite a lot of these children are now being diagnosed through newborn screening. So these children are able to benefit. And this particular group, which responds to ivacaftor, it accounts for 4.5% of the overall CF patients. So this wasn't a huge number that benefited, but at least it was some light at the end of the tunnel for these patients as well. So this is now licensed for 1 month upwards. For that 4.5% of CF patients. Then Orkambi, which is a mixture of lumacaftor and ivacaftor, and this is what you give in the morning, and ivacaftor alone in the afternoon. That became available for over 2 years of age, but that license has now been dropped to over 1 year as well. For that, you need homozygous delta F508 status. So if somebody is homozygous delta F508 and they are over 1 year for age, they can have the Orkambi medication. And then Trikafta or Kaftrio, as it is known in the UK, that came along in 2019. And in between, there was Simcavi as well. And that is effective with at least one delta F508. And that was initially licensed for over 12 years of age. Then the license came down to 6 years of age. And currently, it is now licensed for over 2 years of age. In the United States and in the UK, we're hoping that within the next few months, we'll have that license for over 2 year age as well. So these are very mutation specific. And unfortunately, some of the mutations that we found in Pakistan, they are not responsive to these medications. And although we know the genes, but we cannot use these treatments. And even if we were able to treat these medications, they are very, very expensive indeed. I think they are about, nowadays the prices come down to some extent, and the national price which is sold to the governments is different from the commercial prices. But somewhere between, say in terms of dollars, it'll be somewhere between $150,000 to about $250,000 per year per patient. So it's hugely expensive. But the health economics are, as are shown, if there are people with better lung function, they are living longer, they're not living, needing transplant, they're not needing other medications as much, they will be able to get into work, they'll be able to work and then pay taxes and won't need the medications as much. So they're not using the resources, but they are contributing to taxations, etc. And therefore, it'll be worthwhile in the longer term. And of course, the quality of life, which is very important. It's not just the money. The quality of life will be much better as well. So these medications, 90%, almost 90% of the CF patients will now be on one treatment or the other. And that is a huge achievement as compared to about a decade ago. And I hope that this sort of reflects back in what's happening in Pakistan, and we are able to give the medication to our children as well. So this is I'm talking about the potentiators and the correctors. So potentiators are like the ivacaftor medication, where there was defect. The protein does get into epithelium, but it either doesn't open up the gates or they are not working functioning. The conductance is impaired. So that is where the ivacaftor works. And the correctors, and these are the contents of Trikafta or Kaftrio, they are the ones which help the protein along to the epithelium. So from the Golgi apparatus, etc., they help along to make it to the epithelium, and therefore once it's there, the potentiator can make it work better as well. So combination of potentiators and correctors is being used to help those proteins along. And this is where it corrects the chloride channel and it gets the mucus production, infections, inflammation, and lung function all improved. Now, looking at the mucus obstruction as we think in CF in the patients, what are the ways that we can stop or reduce the mucus obstruction? Obviously, mucus contains fluid as well. So if the body is dehydrated, this could be the hot weather in Pakistan as the temperatures are now into 40s as well. Decreased fluid intake, whether it is due to illness, either child is sick and not able to take it, or whether it's through loss of fluids, through gastroenteritis or sweating, or salt replacement, or salt depleted children through sweating. These are the conditions that will predispose to hydration, which will make their mucus thick and difficult to cough up, and therefore they are more likely to clog up the airways, decreased airways, and infections be more common in those. So make sure that you can prevent the dehydration in these children. And then once the mucus is there are things that can be done to make this mucus more runny, so children can up it out easily. And there are all different, I call them mucolytics. They're not all mucolytics, they're different properties. Hypertonic saline, we don't know how it works really, but it does hydrate the mucus, makes it more runny, and therefore mobilizes easily with the chest physiotherapy. And when children cough, they bring it up. DNase is, again, DNase, as the name implies, this is in the CF lungs, there's a lot of white cells due to inflammation and infection. And cells, white cells, contain the DNA, which is the helix, the structure, and that is what gives the viscosity to the sputum. And DNA break down that DNA components, and it makes it a smaller composition, and therefore it makes it more runny. Whenever DNase is given, you need to leave it in the lungs for at least 1 hour to 1.5 hours before doing the physio to then help the sputum out. N-acetylcysteine is also a mucolytic agent, and mannitol through hydration, which people use it in increased intracranial pressure, etc. as well. So it sort of draws water, and therefore it helps hydrate the airways and get some better. So these are the different ways of giving the mucolytic agents, as are classified more put together, to help thin the mucus. And then, of course, one needs to bring out that mucus, and that is through physical activity, jumping, skipping, running around, bouncing around, trampolining, or doing the physical activity by different devices. And that is to mobilize those secretions from small airways, shift them toward the larger airways, where then child will puff up and bring them out as well. So these are all different sorts of physical activities, which are also good to strengthen the muscles and the bones in children with cystic fibrosis. So always encourage, either individually on its own or with the other techniques of physiotherapy. And physiotherapy, which is little done in Pakistan at the moment, unfortunately. I've just been to Pakistan in December, and I visited PIMS Hospital in Islamabad, Lahore Children's Hospital, Sargodha as well. And one thing that patients are not doing consistently is physiotherapy. And if they are doing it, they are doing very ineffective physiotherapy for a very short period of length of time. There are different, you can read all those things. There are different devices, different ways of doing it. So we do need not only physiotherapists, but we need physiotherapists who specialize in chest physiotherapy. And we don't just need the chest physiotherapists, we need the CF specialist chest physiotherapists as well. And that is a long way to go at the moment. But whatever is available, we should make the most of it at the moment. So avoiding the genes and faulty genes, correcting the genes, getting the mucus or reducing the mucus, and when mucus is there, thinning the mucus and cuffing it out through physiotherapy or physical activities. Those are the preventative measures I mentioned so far. And then it comes down to infections. How can we manage infections? These are the COVID days when you can see everybody is wearing all the masks, and this is where you then stop the spread of infections. And this is preventing things, and prevention is always better than cure. How we can prevent it? The individual infection control measures within the hospitals will have their own policies. There will be hand hygiene things. There'll be special masks or gears people wear during these things. Isolation cubicles when there are infected diseases, or otherwise we always admit our CF patients in isolation cubicles so they are not mixing with the other people. And the equipment they use, for example, nebulizers people are using for CF patients. These nebulizers use obviously liquids with it, and the liquid is one of the stagnant waters or a good medium for the Pseudomonas to grow. So we need to make sure that these nebulizer units, etc., or masks are sterilized quite regularly as well. And also the people avoid stagnant waters like lakes and pools and all those areas where water is sometimes areas around the sink time, for example. So cleaning, sterilizing sinks is quite important as well. Other measures, good nutrition. And nutrition is always very good. If you've got better nutrition, you'll fight off infections very well. And this is one of the most demonstrated benefit of early screening for cystic fibrosis. And then there are immunizations, and you got the EPI expanded program on immunization in Pakistan. They should get their immunization, just like measles, for example, can lower the immunity and cause pneumonitis as well and cause severe pneumonia. So if the children are immunized, then that would be very useful as well. Yearly flu vaccinations, and these should be and are available in all countries nowadays. And they should, all CF patients and the families should get the yearly vaccination. Early diagnosis of cystic fibrosis is quite useful, obviously. Earlier make the diagnosis, preventative measures can be implemented. And this now we have newborn screening things. But if the diagnosis is made early, and this will be only made early if you, as doctors, are going to think about the potential diagnosis of any person who is presenting with the current chest infections or failure to thrive, or the combination of the two, to think about cystic fibrosis on the top of your list as well. And then once you got the infection, then doing the physiotherapy and use of mucolytic agents, using prophylactic antibiotics, and I'll mention that in a minute as well, to prevent infections happening in the first place. And then once they get infection, you need to know what sort of organisms are causing the infections, and that is culture dependent. And then using appropriate antibiotics for appropriate length and appropriate dosages to eradicate the infection. And then subsequently monitoring all those things in the future as well. So it's not just one of the treatment, it's ongoing monitoring, which unfortunately we don't have system in Pakistan set up to review them every 2 to 3 months as we always do in the UK to monitor that. And parents and patients will go from one person to another doctor as well. Although nowadays I'm pleased that through raised awareness and our WhatsApp group and the local doctors, Dr. Danish in Akbar, Dr. Fatima Mir in Akbar, and the other doctors doing the CF work, and similar Children's Hospital in Lahore doing CF clinics, and other colleagues across the country. They are now doing regular CF clinics, for example, or seeing the patient more regularly. Same situation with the Faisalabad situation and Sargodha, etc. So, and Multan, there's lots of them. And sorry, I didn't intentionally miss any of the others as well. It's just a lot more to do. Lots of colleagues are now on board doing a lot of good work, and hope we can carry on with all this good work. Now, what sort of infections do the CF patients get? Well, just like anybody else, they will get all viral infections, which are mentioned about the winter months. Getting them fully flu vaccinated will help. They also get bacterial infections. There are different infections in different ages and different bugs that cause infection in CF in particular. Some typical, some atypical, and there are some fungal infections like Aspergillus, which can happen in CF patients more commonly as well. So all these infections need to be investigated and treated properly. This is from the CF Foundation America, and this is the difference between the last 4 years. And as again, this covers the COVID season as well. So you can see the incidence of Pseudomonas aeruginosa fell from 44% to 26%, and the other organisms, similarly, the incidence halved almost in all of them as well. So these are the preventative measures and also other things along with that, which helped bring down the infection rate. How do we diagnose infection? Well, there's obviously clinical diagnosis, and one needs to look at the symptoms. And clinical diagnosis of infection in cystic fibrosis, what we call an exacerbation, is dependent on the history of change in the sputum volume or color. Where there was a clear color or creamy color, it becomes more green color. And there's increased cough and increased mucus production as well. And they can't sleep, they're coughing through the night, they're feeling tired, they become anorexic. And one of the reasons for anorexia is because the phlegm, which is in their lungs, when they bring it up and they swallow it, it gets into their stomach, and stomach think they got a lot of protein in there, and therefore it suppresses the appetite, and therefore they go off food as well. In addition to infections being catabolic state, so they burn calories. So whatever you got there, they burn the calories, and the weight loss then comes as a consequence of low intake, and so also increased calorie burning as well. And that leads to also lung function, and anything more than 10% is quite significant. Or if people had CT scan or chest X-ray, then they will show changes on that as well. We don't tend to do the X-rays or CT scans very often, and there is no need for it. We do chest X-rays about once a year, minimum 6 monthly, but sort of need to make sure that we don't expose these children to long-term radiation, because every 6 months or every time they get infection, there is no need to do chest X-ray, because at the end, what are you going to prove? You're going to say they got chest infection. Well, the symptoms are going to tell you that, and therefore you need to be more leading or asking them to do sputum cultures and go by the cultures and treat them appropriately according to that as well. So you can do the clinical things, and then the supportive lab work. And this is like I've mentioned, that you can do CRP, what's that count, but they don't actually tell you much. And we tend not to do those things when children come with increased cough and fever and sputum production, because we know they got chest infection. So raised CRP is not going to tell us which antibiotics to use. It just shows they got infection. So we actually tend not to do bloods as much. Serological investigation, and these are like antibodies to Pseudomonas, etc., or against Aspergillus. These can be done in cases where the culture production may not be available. You may not have sputum to send, so you can do serological tests as well. Radiologically, as I said, we do usually one chest X a year. We may do CT 2 or 3 or sometimes after 5 years, but not every time they come into the hospital. And microbiological confirmation, we do every contact. We will take a cough swab or a culture swab. That is the most important thing to do. That tells you what bugs there are. It tells you which antibiotics are going to be effective and how to treat those with the antibiotics. So of those investigations, microbiological confirmation is the most important. However, how do you get the sample for culture? And this has always been a debate in Pakistan. The best culture you could get, most reliable, is bronchoalveolar lavage through bronchoscopy. Obviously, that is not ideal. You can get non-bronchoscopic one, but then again, it's very difficult. It could be on ITU patients or other patients, not readily done. Nasopharyngeal aspirate and swab, yes, again, we can do it under 1 year of age, but over 1 year of age, it is very unpleasant to do. So we tend not to do that either. So sputum, either spontaneously produced or induced sputum is one other way of doing it. Cough swabs, where it's the throat swab that you use, you put it at the back of the throat without touching any side inside the mouth and ask the child to cough. And those cough will bring the organism in the lower down airways and deposit on the cough swab, and that is sent. And labs need to know exactly the way to treat it, and therefore there need to be coordination between the clinicians and the microbiology labs. Cuff plates is the other way, where you got the agar placed there and then ready, what the normally are set up in the microbiology labs. The child coughs onto those plates, and there are different medium plates which you can send to the laboratory afterwards. And throat swab is again, but you can have local contaminants, etc. as well. But that is least sensitive, as it probably sensitivity, but not very specific. It won't tell you what's in the lower airways. But if it is Pseudomonas and child's got a cough, then you got to treat in that way as well. So there's a difficulty in sampling, but those are the ways that they can be sampled as well. And in Pakistan, I hear the difficulties not only taking the sample, but processing, because whenever people talk about mucus sample, the laboratories say, oh, you have to take it empty stomach. And is it for TB? Because that is what they use for. They don't look for other organisms as such. So it doesn't need to be empty stomach. It can be taken anytime, so long as the sputum is good quality. Sometimes children are on antibiotics. We don't stop their antibiotics, to carry on, because if the sputum culture is a good sample and it grows nothing, then we say whatever antibiotics they are must be effective and working. And if they are not, then you will get a culture positive for other things which are resistant to the current antibiotics they're taking, and therefore we can change the antibiotic. So taking the antibiotics is not a contraindication to taking the sputum sample, and it doesn't need to be empty stomach. And laboratory needs to be told that this is from a CF patient, and we are looking for atypical organisms such as Pseudomonas, etc. Which, if you send a throat swab, they were only looking for strep, for example, streptococcus. They won't look for the others. So if you're sending a throat swab, ask them to look for CF organisms as well, please. And of course, correlate it with the clinical status of the child as well. So talking about viruses, these are similar viruses not compared to non-CF patients. These are the common viruses people getting coronavirus for the last couple of years: influenza A, B, syncytial virus, rhinovirus, parainfluenza virus. So treatments tend to be giving them prophylaxis, flu vaccinations, or palivizumab for the RSV in those age groups, and sportive treatment with fluids, analgesia, antipyretics, given oxygen if necessary, and any antiviral specific treatment like the Tamiflu, which people have been using for swine flu, for example. And then if they have secondary bacterial infection, we sometimes do give them preventative antibiotics for secondary bacterial infection. And this is basically to cover the common infections such as Staph aureus, Haemophilus influenza that we have. And if they are growing Pseudomonas and they don't respond to the anti-staph or anti-Haemophilus antibiotics, which we commonly use covamexiclav or flucloxacillin. If they're not responding, then we'll, depending on the culture, switch over to more appropriate oral antibiotics, which tend to be ciprofloxacin In Pakistan, Klebsiella is common and multi-resistant, unfortunately. And in the last few months, we have had 2 children die of invasive Klebsiella, which was multi-resistant. And then the MRSA is quite common, and there's a specific strategy to tackle that as well. So these are the common bugs, and these bugs over age time, they differ. And I'm not going to go through all different curves, but for example, this yellow one here is the chronic Pseudomonas infection that happened. This is the isolated episodes of Pseudomonas, but this is the chronic Pseudomonas as well. So Pseudomonas is the commonest thing. And just to give you some of the numbers, back in the UK 2020 report, there was nearly 32% of the patients who grow Pseudomonas. In 2021, which is the most recent report, only 4.5% of the under 16 had Pseudomonas, and only 20% of the over 16 had Pseudomonas. The incidence over the last 3 years has come down dramatically as well. This is the numbers of Pseudomonas in Pakistan based on the publication in Pakistan. And the very first one was back in 2004, where 41% of these CF patients, and these are aged at the time of diagnosis, aged 6 months, and they have Pseudomonas. So huge number of these patients already got Pseudomonas. The second one was reported 2 years later. Again, 87% of the CF patients in that group had Pseudomonas already. And then the last one was 28%. This is Dr. Danish's study a few years ago. And that was also children, childhood age. And 28% of those patients at the time of presentation, when they came, they had Pseudomonas in their airways as well. So compared to 4.5% in the UK, looking at 28% to 87% of the people in Pakistan having Pseudomonas. And that is universal throughout Pakistan. I just highlighted this slide or these figures from Dr. Danish's publication. And not only that 28% actually have Pseudomonas, but nearly 42% actually have established bronchiectasis on the CT scan as well. So it's a huge number. And I think this is where early diagnosis is very important. Now, this is different bugs in the ages, and this is children of different ages. So this is 4.5% chronic Pseudomonas, but there is chronic Staph aureus infection as well, and we got other things as well. But most of the times it is the Pseudomonas which is the more important. The others are less than 10% in most of the cases. Aspergillus at the bottom, 6% of the CF patients under the age of 16 will have Aspergillus. And these are the number that I've highlighted previously and compared it with Pakistani numbers, 28% in Dr. Danish's study, and it is 4.3%, 2.8%, depending on the age of these children. And then, as I say, lots of bronchiectasis in those patients as well. Other infections, well, we get in the atypical organisms, non-tuberculous mycobacterium and fungal infections. And the treatment, now coming to the treatment towards the end. As I say, this was going to be a short time on treatment. This is culture dependent. If you got a bug, you got a culture, it'll tell you what sensitivities are, and you therefore need to give them those antibiotics. These antibiotics can be oral if the clinical status is stable, or it can be intravenous if they're not able to take orally, or there is no oral option available, or they are sick children. And whenever we grow Pseudomonas, we tend to give them a few months of nebulized antibiotics to suppress the culture. And if we have 3 consecutive cultures which are not grown organisms, then we say it will all eradicated, and therefore we don't need to carry on with the rest of the nebulized treatment. These are the bugs that you've seen originally. Prophylactic antibiotics for early childhood, we tend to use flucloxacillin for up to first 3 years, and there's currently a study going on comparing those who take flucloxacillin against those who are not taking it, and therefore we'll see that in a few years to see what the outcome has been in there. There are some children who are taking cormexiclav, or if they are taking just flucloxacillin and they get exacerbation, we add amoxicillin or change it over to cormexiclav. And they also, some patients, not all, some patients are taking azithromycin as antibiotic prophylaxis and anti-inflammatory as well. Older children, this is certainly over 3 years of age. If they are chronically getting Staph aureus, then we tend to cover them with cotrimoxazole. And over 12 years of age, we can treat them with doxycycline. Doxycycline is not given under 12 years of age, but over 12 years of age, it is fine. And then when we grow Pseudomonas, whether it's the first isolation or intermittent isolation, they both need to be treated similarly, so long we can eradicate it. And if we can't eradicate it, that is called chronic infection. And infection is better term than colonization, because colonization implies it's there but not doing any harm. Unfortunately, Pseudomonas does do harm in the lungs. It causes chronic inflammation and deterioration in lung function. So we take Pseudomonas chronic infection as quite serious as well. We went through the prevention, and we need to do the eradication sort of things and then treatment. So when we have Pseudomonas, as I say, cultures are important. If child is well and they're sensitive to ciprofloxacin, we tend to give oral ciprofloxacin for 3 weeks, and we give them nebulized colomycin or tobramycin, or alternating on a monthly basis for at least about 4 months. This is given twice a day, and we do monthly sputum cultures. And if they remain negative, we say we have eradicated it. If they are sensitive to ciprofloxacin or resistant to ciprofloxacin, then we have given 56 days of continuous nebulized tobramycin instead. And when you're giving nebulized tobramycin, you don't give them IV tobramycin at the same time. If children are unwell, we tend to use 2 antibiotics. Tobramycin, ceftazidime is our choice, but this will be led by the cultures. That's minimum for 2 weeks. Again, added with the nebulized treatment, whether it is the colomycin, promyxin is the colomycin, but in a different format, or tobramycin, or alternating. So these are for at least 2 months of intravenous antibiotics and at least 4 months of nebulized antibiotics with regular cultures. If they are negative at the end of that period, then we say that is fine, we eradicated it. However, a negative culture in the presence of symptoms doesn't mean anything at all, and we will assume that person to have remained positive and will treat it accordingly as well. In the long term, we end up this patient having years of colomycin or tobramycin alternating, and we keep monitoring them, and that is the current advice. If they haven't grown anything for a whole year, or they're antibody negative, or they're 3 consecutive cultures negative, and their lungs are okay, then you can stop their nebulized antibiotics. And these are the available antibiotics, nebulized treatments at the moment: colomycin, promyxin, tobramycin, DNAs or pulmozyme, and inhaled mannitol, which comes as the bronchitol, hypertonic saline, and mannitol as nebulizer. It is important that the sequence of this test therapy is done properly, because people are not doing it rightly in Pakistan at all, and I keep mentioning it. So if you are giving bronchodilators, they must be given right at the beginning. Then you give mucolytic agents, and after they've opened up the airways, after they've thinned their mucus, then you do proper physio. And the nebulized antibiotics, which are to stay in the lungs longer to be effective, you need to give that after the physiotherapy. So that sequence of events, that order of nebulized treatment with physiotherapy is very, very important, and it should be explained to the patients. Other things people are getting are the MRSA. The best thing is to prevent through measures. We have all patients who come into hospital for admission, they have an MRSA screening done to test for it. And if they do have the MRSA, then they have the measures to eradicate it from their skin, and also by oral treatment with antibiotics as well. Or if they can't get oral or they're sick, they get intravenous antibiotics as listed on those slides. So MRSAs are quite common. I've seen it in 3-week-old children. These are hospital acquired, unfortunately, but they can happen in the community as well. There are other fungal infections as well, Aspergillus being one of the common things. Say something about 6% of the children get it, about 10 to 13% of the overall CF population may have it, and they can get the acute bronchopulmonary aspergillosis, which is immune-based reaction, which requires long-term treatment with the oral steroids as well. Candida albicans doesn't need treatment, but certainly Aspergillus does. And then there are atypical infections as listed above, which includes the non-tuberculous mycobacterium and various spectrum of those. I'm not going to go into details of those things because the time is running out as well, and these are very specific things. And I think infection control consultants may need to be on board or need to be taken on board to decide what treatment would be more appropriate as well in those things. And similarly, the non-tuberculous mycobacterium is quite a complex thing in itself, and you need specialists to decide the treatment, because some of the treatment, for example, mycobacterium abscesses, can be up to a year long as well, with IV antibiotics, nebulized antibiotics, and all the rest. So they are not light-hearted infections. They need to be taken seriously and treated seriously with specialist input. So the key point from my presentation is a holistic multidisciplinary team with microbiologists and infection control people, physicians, and technicians. Prevention is better than cure, and surveillance of the bugs that are happening, early treatment to eradicate the infection, and then controlling the chronic infection, the nebulized treatment, and setting up centers and coordinating between the centers, microbiology things, epidemiological base data is all very important in these patients. So this is our YouTube, which Dr. Danish mentioned earlier on. You may visit. It's Pakistan Cystic Fibrosis Support Network. There are about over 50 CF-related topics covered in that, and there will be a few more added. I'm hoping that if we can get this recording, we can upload that on YouTube as well. And you've got my number there on WhatsApp group as well. If any of your doctors, etc., want for any opinion or want to add any of the patients, please do message me on that group, and we'll be more than happy to help everybody. So thank you for your time. Time is just sort of exactly 1 hour, but I'm quite open to any questions.
Thank you very much for the wonderful talk. I think it has really raised our education and learning about the CF, and the background you actually created from this UK data and also the Pakistani data really help us out. So just we want to know about, there are a few questions on the chat box. So starting with the first question, Dr. Abdul Rashid Mehman is asking, so what's an update when we get these therapies, the gene therapies coming into the Pakistan, and how can we compare the practices from the NHS to Pakistan?
So I've shown you some comparison of the numbers and figures and mortality rates. And I think they are there for us to learn from, to say if West can get to that, and they got over 80 years to get there, we can make it as well. The important benefit we have, advantage we have, is that the West actually had to do all the research and find all these medicines to get to that stage. We already have all that. Unfortunately, our financial resources, our medical resources are limited. So how can we get there? I think in the first instance, we need the local Pakistani doctors taking the interest, putting their hand up. And I'm therefore very pleased with all these junior doctors being part of our meeting today to actually take the lead. And I said those negative points about the data and the lack of diagnosis, the resources, let's change that. Let's convert into positive potentials for the future and take that as a challenge. And let's set up the services for CF patients to get that better. And the lead has to be from Pakistan. I've been talking to lots of people in America and other places in our UK CF Trust, etc. Well, I need people from Pakistan to lead locally, and I'm glad the Children's Hospital in Lahore have taken up the steps to set up a regular CF clinic. I know Dr. Danish sees CF patients, but we don't actually have specific CF clinic as such, which will be supported by the CF dietitian, CF physiotherapist, or other personnel. So we need that. And really, honestly, I've mentioned it many times, if we can get 4 doctors in, for example, Karachi, to give half a day of their time as a volunteer per month, then we can have 1 CF clinic every week. Between the 4, they can have 1 clinic every week, and I'm more than happy to support them online for that. So we can get the ball rolling, and these 4 people can work together. And obviously, we can find out where the resources are. Indus Hospital has been very supportive in the past, providing us free accommodation to do the clinic that I did there for 2 days last time I visited Karachi. And if they are able to provide space, for example, accommodation, and there are doctors who are willing to do it, and there are other dietitians and physios to help us along, then we can have those centers. And these clinicians can link in with pharmaceutical agencies and other agencies and NGOs, etc., to attract the medications and funds to make these new treatments available for our CF patients. At the moment, none of the halal earners in Pakistan can afford this medication. I'm not saying there are no other rich people who earn halal can do it, but my wish is nobody has CF. But they may be able, but these will be very few people, and this is a lifelong thing. And if we are talking about a few crore on each medicine per person per year, that to me is not possible in Pakistan in normal circumstance. But yes, there may be individuals, but we have huge charity networks in Pakistan who may be able to help those along. But we need local leads. So if anybody's interested, please get in touch with me. If anybody's interested in setting up the NGO type things or CF trust in Pakistan or something like that, please do get in touch with me and we can work together.
Okay, so another question by Dr. Nasheed about if there's any evidence to suggest role of recombinant surfactant therapy in children with severe pulmonary exacerbation.
Simple question, answer to that question is no. And we don't use surfactant in those children at all. Because it's not surfactant deficiency which is causing the problem. It is the chloride channel defect causing other issues which I've highlighted. So surfactant treatment is not part of the treatment. It's never been part of the treatment, and therefore answer is no.
Okay, so another question, is there any role of steroids and what to give?
So steroids, yes, because there is inflammation there. 1/3 of the CF patients will have asthma or atopic symptoms as well. So inhaled steroids to help their asthma is important, but you need to be identifying on their spirometry or their symptoms or their family history of atopy. So you need to define that what's the likelihood of these patients to have asthma symptoms. So they can be inhaled steroids that they can have. And as I say, this must be given after the physio, or there may be a nebulized treatment. For oral treatments, this is where sometimes they have high inflammation load, which causes high infection load, which causes inflammation. And we do give it a short period of oral prednisolone, for example, for a week or so, whilst they are having their antibiotics, because you don't want to give steroids, which are immune suppressants as well, in the absence of antibiotics, in which case the infection is going to flare up. So once, for example, they have an infection and you've given them at least a week of antibiotics, you think there's a lot of inflammation and they may benefit from oral steroids, then you can give them, they can have 1 millimole per kilogram body weight up to 30 milligram a day as maximum. And there are some patients who may need it for longer, but we can wean them off. They may be on alternate days. That is one area where you can give steroids. The other areas where they got the APPA, acute bronchopulmonary aspergillosis, if they've got that, then they need higher doses for a longer period, and they are beneficial in that. And then we can monitor the IgE in those patients to monitor how responsive they are in addition to their symptoms, and then wean them down over weeks.
Okay, so I think no more questions. So thank you very much, Dr. Ali Akbar. And I think things are really changing in Pakistan. And with the coming up of the genetic testing and analysis, that will really boost our diagnostics. And that's very important. First, we have challenges with diagnosis. And majority of the CF are clinical diagnostic, and they just say, हमें लग रहा है कि CF है, और the problem, they don't have the facility to do even the sweat chloride test in a correct manner. So that's a huge problem. And then comes after diagnosis, there's no awareness about the organisms, about the sputum cultures. That actually we need to really teach and educate our physicians, and that's very important.
Thank you. And that's where I'll go back to my negative side at the beginning. And you highlighted and summarized this very well indeed. And I think these are the areas we need to work on in Pakistan. And I hope these young doctors of today can take the lead on different aspects of this care in the future and benefit their patients. So yeah, I totally agree with you.
So we have a raised hand with Dr. Arshalus. Shafin, can you open the mic, Dr. Arshalus? You want to ask a question?
Yeah, sure. Yes, Dr. Ashulus, please unmute yourself.
Okay. So can you hear me now? Can you hear me?
Yes, we can
Yes,
hear
we
you.
can.
Yes, we can.
So my question is related to Pseudobartus phenomena. In Bartter syndrome, usually the electrolyte picture is almost similar like CF. So any tips so that we can differentiate early? Because to me, lots of referrals come for Barters and later I investigate and they turn out to be CF. So diarrhea is, I know, one of the leading symptoms in GI-CF, but at times it gets masked with polyuria and the parents are confused and so are the clinicians. So any specific tips that you would give us to in the electrolyte patterns so that we can differentiate it early? So
basically, the Bartter syndrome and the electrolyte disturbances came to light in 1948 during a pandemic of diarrhea, and where children had profuse water loss, etc., and had chemical stability. And this is where they got the chloride was abnormal, their magnesium was abnormal, their other cells, sodium was abnormal. And these were highlighted at that particular stage. And these are the patients who subsequently, quite a lot of those who were diagnosed CF. So not everybody with dehydration will have the Bartter syndrome, but if you got the electrolyte imbalances with especially chloride dipping down to less than 95, then you need to think about those things as well, in addition to the magnesium changes that may happen as well. These patients may not be polyuric because there are obviously other renal problems that can happen as well. And these patients with the metabolic illnesses can also have failure to thrive. So one needs to go back to the basics of their symptoms. Are they having, is it diarrhea, infective diarrhea, or is it malabsorptive diarrhea with stool, fat globules and fat in it? And do they have fecal elastase, which is less than normal and showing pancreatic insufficiency or not, which majority of the patients would be. So we need to put in the clinical context of what their diagnosis and problems and issues are, and take up in those fashions. So when you do have the electrolyte imbalance, you need to think about, it may be one of the CF things, but it's not the commonest presentation. It can be electrolyte imbalance, but it's not the commonest thing. You need to still think about the other renal causes or other metabolic illnesses as well to what's causing it. But do think CF as part of the picture.
Thank you.
Another question, can we use mannitol as a nebulizer?
So I think this is where mannitol is not currently used as a regular. It is being used in some centers, some places, and it's not the, it's probably more expensive as well compared to hypertonic saline that's available in Pakistan. So let's not go for fancy things, go for the common useful things. But yes, it can be used. It can be inhaled as well. So you can use it in those formats. But yes, it can be used if necessary. But it's not the only thing that you can use or should use. There are other simpler measures which give you effectively the same outcome.
Okay, so I think there are no more questions. There's a small announcement by Dr. Amima Asad. If you can make Dr. Amima, Shafin, can you open the mic of Dr. Amima, please? Just want to make update about the genetic testing we are doing so that all the doctors from across the Pakistan know about it and they can contribute to our this genetic study.
Hello, Assalamualaikum. Thank you, Dr. Ali Akbar and Dr. Danish, for organizing this session on cystic fibrosis. Also, I would like to add that currently we have organized a research study in which we are doing free of cost genetic testing for our CF patients. And the unique thing is that before the study, we just had the test for Delta 508, but all other mutations, which are currently over 2,000 more variants of CF, right? And they were not detected within Pakistan, and we had to send samples abroad. But now, as a part of this research, we are doing those testing also free of cost. And however, I feel that the dilemma comes with to see that how many patients are highly suspected of CF and how many patients are low-risk patients, right? And this can only be sorted if opportunities are made available by sweat testing or sputum cultures. However, that's also not necessary because in some patients we see we get a thorough history and we also see their clinical signs and symptoms like clubbing is there, recurrent chest infections are there, FRCT shows bronchiectasis, right, as mentioned in this presentation. So we enroll those patients and we take their blood samples. So I think that it's a very good opportunity and doctors can also refer their patients across Pakistan, not just limited to AKU. Thank you.
Thank you,
Thank you
Dr.
very
Akbar.
much.
Thank you very much indeed for your help. I think it's a great help for the community as well. There's a one question flashing up. What test when we can do in neonates? Is it enough time for me to answer that?
Yeah. Go ahead, Doctor.
Okay, so
Go
in
ahead.
the neonates, obviously if somebody's got pneumonia or there's family history, because you can get obviously pneumonia in the newborn area anyway. For just in first infection doesn't necessarily mean that they got CF. If you were to do any testing, then once they are on full feeds, you can do fecal elastase 1 test for pancreatic sufficiency or insufficiency. Neonatal babies, you can do sweat test, but baby has to be over 3.5 kilo or 4 kilo in weight, which not many newborn babies are. And if they are, then they are less likely to be CF anyway. So you need to wait for that, and you need to have local good opportunities to do the sweat test as well. But sweat test over 3.5, 4 kilo babies can be done. Genetic testing can be done at any age, even in the prenatal period as well. And that you can do that in the neonatal period as well. So fecal elastase test can be done in the neonatal period. Genetic testing can be done. Sweat test may or may not be possible, or local procedures may not be available at that time. But certainly over 4 kilo child, we are able to do that. But sometimes if you get insufficient sample, it needs to be repeated as well. So it can be done, but not necessarily immediate neonatal, but need to wait until child's about 4 kilos in weight.
Okay, just one last question regarding the aspergillosis. So we repeatedly get aspergillosis in the sputum cultures. And so when should we treat aspergillosis? Should we see the IgE levels coming up high, raising up, and then we should treat, or should we wait and we should treat every aspergillus?
So not every aspergillus needs to be treated. Aspergillosis, the fumigatus is the common one, which causes acute bronchopulmonary immune reaction, and that is where the IgE will be raised. So what we tend to do is, if, for example, they've got just the culture positive for Aspergillus fumigatus, we will treat with itraconazole, and we will do total IgE. And if total IgE was raised more than 500, then we ask them to do specific IgE to Aspergillus fumigatus. And if that is raised, then we will treat them with steroids as a BPA.
Okay, thank you very much. I think we don't have more questions coming up in the chat box. So the final words from Dr. Ali Akbar, and then can we sign off? Thank you.
Well, my final words are thank you very much, Ashley, for being there. And it just shows that you guys are very keen and interested in the condition. And I hope the younger generation can take it forward and make life easy for their patients and excel in your own field. And I wish you all the very success. And thank you very much for being part of this talk.
I think thank you very much. You are the mentor for many doctors across Pakistan, and I really love your enthusiasm and your dedication towards the CF network in Pakistan as well as across the UK. And so people are learning, and I think things are changing very quickly for us as well. So we are learning and we are applying, and we are doing in a very small pace, but hopefully, inshallah, in future, we will get all the facilities and all the drugs and all the medication available in Pakistan as well. Thank you very much, and thank you all the audience and all the people. Thank you very much, and see you for next time for the more guest lectures like this. Thank you, Dr. Ali Akbar.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam.